Welcome to this session on dizzy patient, a practical approach to diagnosis and management. Dizziness is one of the most common and most challenging presentation in clinical medicine. It can be benign, like a brief episode of positional vertigo, or it can be life-threatening, like a posterior circulation stroke. By the end of this talk, you will have a clear framework to differentiate these causes, recognize key red flags, and most importantly, never miss a stroke just because the CT scan was normal. Learning objectives of this session include understanding basic physiology of balance, as normal functions help explain what goes wrong. Secondly, differentiate four main types of dizziness. Remember, dizziness is not a diagnosis. It is a patient's description, and your first task is to determine what they mean. Thirdly, identify red flags that suggest serious underlying pathology. And finally, focused balance assessment, including hints examination, which can be more sensitive than early MRI for detecting stroke. Now let us start with the real case that changed how I practice. A 65-year-old man presented to the emergency department with sudden severe dizziness, vomiting, and inability to stand. A CT brain was performed and came back completely normal. He was discharged home with a diagnosis of vertigo. 48 hours later, he returned with a large cerebellar stroke. Here is the critical point. The problem wasn't the CT scan. The problem was that a proper bedside examination was never performed. The CT was normal, but the patient could not walk, and that alone should have indicated that this was not simple vertigo. So why dedicate an entire session to dizziness? Firstly, it is incredibly common. It accounts for 5 to 10% of all primary care visits and is the most common complaint in elderly patients. More importantly, the stakes are high. The spectrum ranges from benign positional vertigo to life-threatening posterior circulation stroke. Your role as a clinician or future doctors is to navigate this uncertainty and identify the patients who need urgent intervention. Let us consider an important question. Let us start with a quick question to frame our thinking. Which of the below finding is most concerning in a dizzy patient? Nausea, hearing loss, severe gait ataxia, tinnitus. The correct answer is severe gait ataxia. Why? Because the inability to walk independently suggests central nervous system involvement until proven otherwise. Nausea, hearing loss, tinnitus can all occur in peripheral vascular disease, but severe ataxia, especially if the patient cannot walk, is a red flag for stroke. This is an important finding. It will save lives. Now let us review how balance works. Balance depends on three sensory inputs working together. First, vision, providing spatial orientation. Second, proprioception, the sense of body position from joints, muscles, and receptors in the spine. And thirdly, the vestibular system in the inner ear, such as semicircular canal and labyrinth, which detects rotation and gravity. These inputs are integrated by the brainstem and cerebellum. Dizziness occurs when one system fails or when signals conflict. Think of being on a boat. Your eyes and inner ear send conflicting signals, leading to dizziness. Dizziness is not a diagnosis. It is a symptom description. Your first task is to classify it into one of four categories. First, vertigo, a spinning sensation suggesting vestibular pathology. Second, presyncope, the feeling of nearly fainting, usually cardiovascular. Third, disequilibrium, unsteadiness when walking, often neurological or musculoskeletal. And fourth, lightheadedness, a vague sensation, often metabolic, medication related, or anxiety driven. Always ask, what exactly does the dizziness feel like? The answer guides your entire assessment. Red flags. Before anything else, rule out red flags. Neurological red flags include weakness, focal, slurred speech, double vision, and severe ataxia, especially inability to walk. These suggest central pathology until proven otherwise. Cardiovascular red flags include true syncope, chest pain, palpitation, pointing to arrhythmias or hemodynamic instability. If present, these require immediate attention before continuing routine evaluation. Once the red flags are excluded, three questions diagnose most patient. First, when did it start? Continuous or episodic? Second, what triggers it? Movement or standing? Third, are there associated symptoms, neurological or auditory? These three elements, timing, triggers, and associated symptoms, guide diagnosis in most cases. History framework. By applying this framework, helps us to narrow down the diagnosis. For example, if it's a continuous vertigo, it suggests vestibular neuritis or stroke if neurological signs are present. Episodic vertigo may indicate vestibular migraine. Brief positional vertigo suggests benign paroxysmal positional vertigo. Symptoms on standing suggest orthostatic hypotension. The pattern directs the diagnosis. Physical examination may start with vital sign, including orthostatic measurement. Next, perform a focused neurological examination, including cranial nerves, eye movements, and coordination. Most importantly, assess gait. Can the patient stand unsupported? Walk independently? Is there ataxia? If the patient cannot walk, treat it as a central cause, proven otherwise. The 10-second cerebellar stroke test. Ask the patient to stand and walk. Support them if needed. If they cannot walk independently or severely ataxic, suspect cerebellar or brainstem pathology. Remember, severe vertigo plus inability to walk equals central cause until proven otherwise. Hind's examination. For continuous vertigo, Hind's examination is essential. It includes head impulse test, nystagmus assessment, and test of skew. You can pause the slide and have a look on the uses of Hind's test and when you should not do Hind's test and significance of the test in central and peripheral vertigo. Interpreting hints, it is important to understand which signs suggest central cause. For example, normal head impulse, direction changing nystagmus, positive skewed deviation, while peripheral causes require all opposite findings. Here, a key point is in severe vertigo, a normal head impulse is abnormal, suggesting a central cause. In this slide, we summarized peripheral versus central nystagmus features. Peripheral nystagmus is usually horizontal, unidirectional, and suppressed by fixation. Central nystagmus may change directions or be vertical or torsional and persist despite fixation. Central causes often produce severe ataxia. Always remember, vertical nystagmus is central cause until proven otherwise. Remember this mnemonic BVOMES, where B stands for BPPV and the others are vestibular neuritis, orthostatic hypotension, migraine, and finally stroke. Here we briefly discuss about benign paroxysmal positional vertigo, which is the most common cause of vertigo. It presents with brief episodes triggered by head movement with a short delay before symptoms begin. Common triggers include rolling in the bed, looking up, or bending forward. Symptoms are brief because the brain rapidly adapts to the abnormal inner ear signal. Diagnosis is confirmed by Dix-Hallpike test. Dix-Hallpike test is done routinely, and if you pay attention to the technique and the images will help you to understand how it can be done safely in the clinic, in the emergency department or family medicine clinic. A positive test shows reproduction of symptom, torsional nystagmus, latency, and duration usually under 60 seconds. This confirms posterior canal BPV on the tested side. Once BPPV is confirmed, there are several test or bedside treatment options available with successful outcome and resolution of symptoms. Perhaps you want to pause the video and look about each test on YouTube if you wish to learn more. Appelé maneuver is commonly used to treat posterior canal BPPV and is highly effective. Alternative to Appelé is Semot's maneuver. For horizontal canal BPPV, use the barbecue roll or Goffoni maneuver. And for anterior canal BPPV, you can use deep head hanging maneuver. Now we spend few seconds on posterior circulation stroke. The diagnosis we must never miss. Warning signs include inability to walk, double vision, slurred speech, and limb incoordination. Particularly be conscious in older patients with vascular risk factors. A normal CT scan does not rule out posterior stroke. If the suspicion is high, after discussion with the neurologist, proceed with MRI for stroke evaluation. 5 common mistakes to avoid. Relying on the CT scan to exclude stroke. Not assessing gait. You may miss the important sign. Skipping the hints exam if indicated. Using vertigo without clarification. Ignoring timings and triggers. Avoiding these mistakes improves early diagnosis and outcome. Now finally, key takeaways from this lecture. When assessing a dizzy patient, always ask about timings and triggers. Check if the patient can walk. Recognize central nystagmus. Use Dix-Hallpike when appropriate. And remember, a normal CT scan does not exclude posterior circulation stroke. Bedside examination is your most powerful tool. Trust your clinical skills. They save lives.